All right. Good morning, everybody. Thank you so much for being here today. I am going to kick it over to Neosha, our president and CEO.
Good morning, everyone. Oh, I need some more excitement. Good morning. Oh, fantastic. I just want to thank you all for being here this morning. And I'm really excited to see a lot of new faces. If this is your first network meeting, can you raise your hand? Oh, fantastic. Well, let's give them a round of applause for joining us this morning. Thank you. Welcome to the network. We're really excited to have this conversation. I'm really excited to see all of you. And I just want to say thank you for joining us this morning. And shout out to Gabby for putting together this great panel. And we can't wait to hear and learn more. So I hope you all have a great day and enjoy what we have in store. Thanks.
All right. So the precipice or the reason behind this meeting today is we've heard so many of you who work with your families and your clients who are needing services but don't necessarily know where to start. And when they do start, what's the next step? And when they do start, are they insured or underinsured? And what does that even mean? So we brought together a panel anywhere from healthcare, how to navigate that system, to prescription medications. How do you access that? And what does that cost look like? To advocacy as a patient. What is that? If you want to stand up for yourself or your family, where do I start with that? And who do I even look to as a guide or a leadership for that? Or if I want to start on my own, what does that look like? And we also have one of our newest members, Autism Support Now, who is leading right now in North County of supports for children on the spectrum. They are growing and expanding. We're really excited, but also there's some misinformation and some troubling things that are going on right now in the media about this subject in healthcare. And where do parents look to now as we already deal with the stigma of children on the spectrum? So we are going to kick it off with Erin Murphy of St. Louis Integrated Health Network.
Hello. Okay, awesome. Good morning, everyone. I'm going to stand up so I can talk. We can go to the first slide. So, I'll introduce myself, I guess. I'm Erin Murphy. I'm the Associate Director of Clinical and Community Integration for the St. Louis Integrated Health Network. And I am going to talk about the program that I oversee, which is our Care Transitions Initiative. You can go to the next slide, Gabby. Awesome. All right. So within our Care Transitions Initiative, our main goals are to enhance access to primary care home and health resources for all patients, regardless of ability to pay, reduce non-emergent use of emergency departments and low acuity readmissions. So helping individuals who maybe are coming to the ED for prescription refills, things that could be handled by a primary care provider, trying to work with them to make sure that they have that care established. And then enhancing continuity of care, and then strengthening communications and processes among safety net providers. So the three facets are that patient engagement and navigation, our systems coordination, and our health promotion and advocacy. And I'm going to get into these three facets of the Care Transition Initiative at the IHN. Next slide. Okay, so our core services that we provide through the CTI is our systems coordination navigation, which is our transitions of care task force, our health education model, which we call Pulse, and then our patient advocacy, which is our community referral coordinator program. And you'll see kind of all of these within our systems coordination navigation, works on population health management, meaningful use, community benefit, centralized referral data repository. And then our PULSE model is an education framework that we use to guide patients around discharge and follow-up care. And then our CRC program works to overcome those barriers that patients have when accessing care. And it's a patient-centered approach that we utilize. You can go to the next slide. All right, so now I want to get into a little bit more about those three things. So our Transitions of Care Task Force is a cross-functional group of providers and health leaders, and it's focused on strengthening that collaboration within policy issues from that systems perspective to improve those transitions of care across the system. So this is a quarterly meeting that we hold with individuals from the hospital systems, FQHCs, community resources, anyone who is involved involved in that transitions of care process, we want them at the table because we want to talk about what they're seeing, what they're struggling with, how we can collaborate and come up with solutions to those issues. So, like I said, the goal is to promote high quality, safe, and efficient patient transitions of care between a hospital and an outpatient setting. And so some of the things that we have worked on over the years is looking at patient experience surveys regarding that care transition, improving the communication via the electronic medical records. As we know, most of the hospitals are on Epic, but the FQHCs, not all of them have access to that system. And that creates a lot of issues. So working to kind of hopefully move towards a more collaborative way of sharing patient information, and then defining a transitions of care standard for the region, and then expanding to include sickle cell disease care transitions between PCP specialists and hospital EDs. Next slide. So Pulse, this is our educational framework. So this is what we utilize within the hospitals and within the community to talk to patients about what level of care they should be accessing for certain things. So like I said before, patients who come to the emergency room for prescription refills, we want to have a conversation with them about why it may be a better choice to go see a PCP. We are never here to force anyone to have a PCP. We just want to provide that education so they can make their own informed decisions about it. And so the PULSE acronym stands for primary care, urgent care, living well, specialty care, and emergency care. So when should you be accessing those levels? And so that's what we utilize with our CRCs when they go talk to patients, talk to community members to talk about how the system's laid out and when you should access those things. Next slide. All right. So who is a CRC? So these are our community referral coordinators. It's a patient-centered intervention, and we work with patients and community members to assist in understanding and navigating health and social CRCs, so they connect patients from inpatient units and emergency departments of hospitals with a primary care home for follow-up and preventative care. We focus on serving underinsured and uninsured patients, but we do work with all patients in need of a medical home, but we do prioritize those patients who are underserved. So our community referral coordinators are employees of the IHN, and we are contracted through the hospital. So we are not employees of the hospital systems. We're kind of this beautiful little in-between of a way for us to also, it makes it easier for us to have those conversations with patients. For instance, if they're having a really bad experience in the hospital, we're able to come in and say, we don't work for the hospital. Tell me what's going on. Tell me how I can help you. So it's a really nice place to be in terms of that coordination. All right, next slide. So this is just a map kind of showing our reach within the region. So our focus areas, we work with the 4 FQHC systems, 2 public health departments, 2 medical schools, 3 major hospital systems, a partner member, and then 2 technical advisors. So then you'll see the list of our partners below. So all the FQHCs, St. Louis University School of Medicine, Washington University School of Medicine, health departments, BJC, Mercy, SSM, Department of Health, Missouri Primary Care Association, and then the Regional Health Commission. So I really like this map because it really shows how far we stretch around and how many people we're able to help. Next slide. Okay, so this is just an evolution of our CRC program. So it started in 2007, so we are 2 years away from it being around for 20 years, which is very exciting. We started out as a grant-funded program, and we had 2 hospitals with 2 CRCs. So we started out in Barnes Jewish in the ED, and then at St. Mary's in the ED. In 2011, we expanded to inpatient, and then in 2012, we put an emphasis on established community health center patients. So any patient coming through the hospital that we see is established at Affinia, Care STL, People's, Family Care, we want to talk to them because not only do we want to connect patients if they don't have a PCP, we want to reconnect them with their primary care provider as well. So that's really important to us. So in 2014, we moved from grant-based to hospital contracts. So the hospital provides the funding for us to come and provide these services for their patients. And then in 2016, we started tracking those social determinants of health factors, and then focusing on that transition of care and development of additional referral partners. And then in 2019, we added community-based CRCs. So we have 2 community-based CRCs, and they will go to events, anything where community members could benefit from this service. We want to make sure we're having conversations with those individuals as well as the people that are in the hospital. So as of now, we have 1 CRC at Barnes-Jewish Hospital, 1 CRC at St. Louis Children's, 2 CRCs, well, 1.5, at Christian Hospital, and 2 CRCs at Memorial Hospital. And then 2 at St. Mary's, 2 at DePaul, 2 at SLU, 1 at Cardinal Glennon, and then we also have 2 float CRCs, and those individuals provide coverage. So if we have someone who goes on parental leave or is out ill or on vacation, they come in and cover so that we assure no patients are falling through the cracks. All right, next slide. So this is our referral process. So this is how we work within the hospital systems. All of our CRCs have full Epic access, so they're able to receive referrals from social workers, case managers, providers, anyone who has a patient come through that needs that assistance. We want them sent to the CRC, and the CRC will go talk to them in person and have a conversation about their needs and how we can help them. And like I mentioned before, this is a patient-centered intervention. We're not here to sell anyone on a PCP or any particular provider. We want to make sure that the access they're getting is the access that they need and want. So maybe it's not the health center by your home. Maybe it's by your kid's school. Maybe it's, by your work. There's so many options, and we want to make sure that we're providing all those options to ensure that they make that connection. Because if you're just scheduling people to schedule people, they're not going to go to those appointments. You got to talk to them about it. We also follow the patients after they leave the hospital leading up to that appointment. So we're not just dropping them once they're discharged. We're keeping up with them in case things come up, barriers arise that we need to address, making sure that they get to that appointment. So when we get a patient referred to us, if they have no PCP, they have no insurance or Medicaid, they're established at an FQHC, or they're an ED high utilizer. These are the main patients that we really want to connect with. The referrals come, like I said, from care management, social work, CHWs, providers. If they are established or have a PCP, we're going to talk to them in person, let them know. We're going to get them set up with an appointment for follow-up after they're out of the hospital. If we're unable to meet them in person, because we do work normal hours, so we work Monday through Friday at the hospital, so we do receive those referrals overnight on the weekends. We'll reach out via phone to try to connect with them. That is a little harder. Our main goal is to see patients in person because we know that face-to-face connection is going to make all the difference in that connection rate. If they do not have a PCP or are not established, we'll have a conversation about if they are interested in our assistance. If they're not, totally fine. We'll give them our contact information and say, if you ever change your mind, give me a call. I'm always here to help. So then if they do want an appointment, we figure out where they prefer to go, and then we send a password protected Word document to our contacts at the FQHCs. And the goal is for them to respond 24, 48 hours to give us that appointment information back. We reach back out to the patient, let them know when their appointment is, and like I said, follow them up until that appointment happens to make sure that they get to that connection. Next slide. Okay, so this is just kind of an impact of what we do. So you'll see in this chart here, when we started in 2009, our show rate, so the amount of patients that we encountered and were scheduling, was 29%. Last year, it was 53%, and then the 3 years before that, it was 60%. So we have really improved our processes, really worked hard to increase that show rate, make sure patients are getting to those appointments. So we've helped thousands of patients and community members get connected with PCP services since we started. We have assisted over 200,000 patients as of 2022. And in 2023, we scheduled over 2,000 appointments just with the health centers alone. So we also do schedule with the major hospital systems. If a patient prefers a Barnes doctor or an SSM doctor, we'll schedule that as well. But in 2023, we did schedule over 2,000 appointments just at the health centers. So compared with traditional ED diversion programs that focus on those avoidable 90-day readmissions, our model centers on the process of connecting patients to medical homes, predominantly the community health centers, providing greater access to comprehensive care and wraparound services. By anchoring those patients to the community health centers and addressing those SDOH factors, we achieve higher than average show rates, like I said, at the community health centers, and a 21% reduction in avoidable hospital readmissions, which is great. That's what we want to see. And then the Transitions of Care Task Force. So it's been really instrumental in working to increase this show rate for sure over time, and then bringing more patients to those community health centers. So by bringing everyone to the table, that's what's important. Just like this group, like that's what's important. Having those conversations, seeing how we can partner and collaborate and support the people that live in this region. Yeah. So that's pretty much. I think that's what I was like. Yeah. That's the program.
Thank you. I have a couple questions, but if you have any questions, we can also pass the mic around. But one of my questions, Erin, is what are the delays looking like right now to connect someone who doesn't have a primary care provider to a provider? Mm-hmm. And what does it look like the next steps when if and when those delays are significant?
Absolutely. So we keep very abreast of what the timeline is in terms of appointment availability at all of the FQHCs and anyone that we may schedule with regularly. Obviously, I think all of us know workforce is a big issue. It's hard to keep staff. There's a lot of turnover. I think at most organizations right now, including the FQHCs. And so it really does shift, but our CRCs are always aware of which health centers have that quick availability. We also work with the hospitals and have access to their transition clinics so that because we want to get them established. And so say an appointment is maybe like a month and a half out. If they need to see a follow-up within 2 to 3 weeks, which is pretty typical if you're in the hospital for something serious, we will schedule an appointment with the transition clinic at the hospital, and then they can get established with the FQHC later on. So we have these processes in place to make sure no one is ending back in the hospital. That's the ultimate goal. We want to reduce that non-emergent visits and the readmissions. And so yeah, we really make sure that all of our CRCs are on top of what the availability is, where we can schedule, who has the capacity.
Amazing. And then my second question, if anyone else also has a question, please raise your hand. But what do translation services look like for some of the immigrant families whose primary language is not English?
Absolutely. So within the hospitals, we have access to language services through the hospital. When we request those appointments, we always make sure to let the FQHC know that this individual speaks a different language. We let them know what language, and we make sure that when they get to that appointment, translation services are available to them. That's a big part of what we do, because obviously that's very important.
Oh, we got some questions out here. Can we get a microphone over here? And while we're getting that microphone, sorry, I'm going to monopolize your entire time. I know we're talking about primary care, and I think we can have an entire meeting on specialty cares next. Mm-hmm. But what are some of those next steps when someone finally sees their primary care provider? Where does the CRC go to schedule, whether that is a mental health appointment or dermatology or ortho? What does that look like?
Absolutely. So we also schedule specialty appointments. PCP is our main thing that we do schedule, but we will work with, we know what all the FQHCs offer. If they don't offer that specialty service that patient needs, we will figure out where we can get them in, whether that's a hospital partner, whatever the patient needs, we're going to figure it out and make sure they have. But we also are very aware of how insurance works, and a lot of insurance plans, you do have to get established with a PCP prior to seeing a special provider. And so we always make sure to let patients know this is the process. We have to get you set up with that PCP first, and then we can get you in to see specialty services.
Question in the back.
I was wondering from your presentation, do patients have to be hospitalized in order to access your service?
Absolutely not. So that's why we have those community-based CRCs. We also utilize the hospital CRCs, will utilize the community-based CRCs. If we have a patient who has a lot of SDOH needs and a lot of barriers, we will refer them to a community-based CRC because they have a lot more capacity and time to really work with that patient and figure out how they can tackle all the things that are going on in their life. But like I said, we go to community events. We have a referral page on our website that anyone can go in and refer someone to our community-based team.
And then the next question I have is, do you also assist patients in finding a new provider in the event that their current provider no longer accepts their insurance?
Absolutely, yes. We also keep up to date on what providers are taking what insurances, so that we're never sending a patient to a provider and them getting there and being turned away. That is number one. We never want that to happen. And so we are always aware. We also, with some of these insurance plans, they will assign you a provider. And a lot of patients don't know that that is what's happened. And so we will look at their insurance card, see if there's a provider listed. If it's not if they want to go see a different provider, we'll work with them to get that switched on their card, because we always want to make sure they're able to access services and it is covered by their insurance.
I have a couple questions as well. One is, are the appointments that you're making also impact mental health, so psychiatric trauma, those kinds of things? Okay.
Yes.
And the other question is, can you explain what FQHC?
Oh, I'm so sorry. Federally Qualified Health Center. I'm so sorry. I use a lot of acronyms. Yeah. Federally Qualified. So that would be Affinia, Care STL, People's Family Care. All of those health centers are our partners, and we work with them. We have contacts at all of those sites to be able to schedule quickly and proficiently.
All right, and we have a question from the Zoom also. So what are some of the interventions that IHN has implemented to improve appointment show rates?
Yeah, so I think honestly the biggest thing, those in-person connections, having a face-to-face conversation with a patient about the plan and the timeline. I'm going to reach out to you. This is my phone number. Put it in your phone so you know it's me. Because this day and age, nobody answers their phone for random phone numbers. So we want to make sure that they know who we are. We're going to reach out to them. Tell us what's a good time and a good day that we can talk to you about your appointment details. So really making sure that we connect with those patients. They know who we are and that we're going to do that. And also following them up until that. I think that's a big deal, because if they get discharged and we're not connecting with them as that appointment gets closer, it's very possible they're not going to make it. So just being really diligent about that.
Yeah, and I have a part 2 for that question. So how does your organization address copay issues?
Okay, so we also provide as much information as we can to the patient, specifically if they are uninsured, which is why we do partner with the federally qualified health centers, because they work on that sliding scale if you are uninsured. So letting them know these are the documents you need to bring to your appointment to be put on that sliding scale. We want to make sure that they have everything they need when they get to that appointment, once again, so they're not turned away. So yes, we provide probably more you're in the hospital, you get so much paperwork in general, but that's also why we contact them after they're out of the hospital, because it's really overwhelming being in the hospital. And so we want to give them time to kind of settle in after they're discharged, and then connect with them again to remind them about all of the things they need to bring to that appointment to be able to get on that sliding scale.
Great. And we have one more question, and then we'll move on to Asia.
Hey, quick question. Darius Rucker here with iThrive. We provide mobile vision care services for kiddos.
Okay.
We have an optometrist on board, and they provide referrals.
Yeah.
I heard you say they might need a PCP before the specialty. If the optometrist provides that referral, is that something we can connect with? Because we are having some challenges.
Absolutely, yes.
Sweet.
We love referrals.
Awesome.
All right. Thank you so much, Erin. Wonderful presentation. Like I said, this this conversation can be definitely longer, and we can, hit some more target specific issues that you're seeing in the community. So we do have a survey. If you can let us know, obviously we know mental health is going to be a top one, but let us know also what other some of those specific or maybe even niche services are that we can start connecting and making those connections to those providers. But next, I am excited to welcome Asia Owens. You're welcome to use your.
Good morning, everybody. I'll just stand up.
Sure, you're welcome.
Good morning, everybody. All right. Fun fact: this building, I went to kindergarten here like 35 years ago. But anyway, it's interesting to see how it has repurposed. I'm gonna take this mic off. All right, so good morning. I am Asia Owens, and I am here representing the Community Health Commission of Missouri. I serve as their Advocacy Mobilization Manager, and basically what that means is I work in community with individuals who need access to health care, and then also work in partnership with legislators, policymakers, community organizations to help them connect to the care that they need. So this first slide and illustration is just to kind of show you some of the partners that we work with in community, such as like St. Louis City government, county, city and the county government, federal officials, area hospitals, medical schools, specialty clinics, like you mentioned, the FQHCs, community physicians and dentists, behavioral health professionals, health advocates, neighborhood organizations such as the ones here today, and residents and patients of health systems. So we are a Missouri-based organization, but we also serve Kansas City, the Southeast region of Missouri, as well as St. Louis. And so we work all around the community throughout the region to work in partnership with organizations and promoting like trauma-informed care practices as we do this work. So our mission is all about eliminating health disparities. So a lot of the work that we do, especially in advocacy, is to go back to that mission of eliminating health disparities, particularly with those underserved and marginalized communities. And we can go to the next slide. So I'm going to just kind of list some of the advocacy efforts that we do in our organization: community listening sessions, youth ambassador program, show me advocacy workshops, advocacy days at the Capitol, engaging legislators, town hall meetings, providing testimonials before the elected bodies, and voter education outreach. So the next slides will just kind of talk about those. So let's talk about the community listening sessions. I love these. Darius, do you see yourself on there? Yep, you see yourself? So these are just different community members. We come together to have conversations about what are some of the barriers that you have in regards to healthcare access, and also like talking about what are some of the solutions, what are the things that you would like to see. And so again, that information that we get from those community listening sessions when we're at the Capitol or when we're engaging with the legislators, we're using this real information through storytelling and listening sessions to capture the voices of those marginalized communities in order to help change those policies. We also have partnered with the St. Louis City Department of Health to do community forums. We've done two so far. We actually just did one yesterday with the trans and the non-binary community, and we hosted one in January with the Black women. And again, just talking specifically about what are some of your barriers to healthcare access, and then what are some of the ways that the agencies can support you and as you navigate your healthcare experience. So these community listening sessions are really important because, again, data and research is very important. However, when we couple that with the lived experience, especially when we're engaging our legislators, it really just drives it home, whatever the issue or cause that we're working toward, which we are really, really strong proponents of advocating for Medicaid. So when we're talking to those legislators, we're using these lived experiences from the community members to help, just really drive that home for us. We can go to the next slide. We have a youth ambassador program, which we're really excited about. And again, we're in St. Louis and Kansas City. So we have kiddos from, middle school, high school, primarily high school. But when we bring them together, we talk to them first about trauma. And I forgot to mention, as far as us being a merged entity, we are merging Alive and Well Communities with the St. Louis Regional Health Commission. So now we're known as the Community Health Commission of Missouri. But Alive and Well Communities was really, really strong about educating the community about trauma. So first we talk to these young people about trauma and why we show up the way that we do, but then we also talk to them about the importance of being civically engaged and getting involved in community. So what the kiddos did last year was worked on 5 priorities that they wanted to talk to their legislators in Jeff City about. And they were supposed to go to Jeff City, but since we couldn't do that, we brought Jeff City to them. So in Kansas City and St. Louis, we brought some of the state legislators to them so that they can still talk about those priorities that they would like to see changed. So we are really excited about this program. I think that we are right now working on funding to keep this program going because it was really, really effective. Show Me Advocacy. So we also do workshops around just advocacy 101, just talking like, I know last week we were at Slate with the young people there with the youth employment program to just talk about, what are some of the ways that you can get more involved and know who your legislators are. Sometimes people don't even know who their mayor is, who their aldermen are. And so we just do a lot around just educating them on just the basics of advocacy. Next slide. We've supported a lot of advocacy days at the Capitol. Actually, there's something going on today. I know that there was a bill just passed yesterday around abortion rights. And so a lot of advocacy groups are coming together today at the Capitol to just kind of speak out against that. So one of the things our organization do, while we realize that it's very important to collaborate with other organizations, other advocacy groups, we come together, whether that's doing sign-on letters, petitions, rallies. So we've spent a lot of time this legislative session at the Capitol, just around advocacy, around reproductive rights, again, Medicaid and things like that. So spending time at the Capitol to make sure that the legislators know where we stand and when we're in solidarity with other groups that's doing the same thing. And I talked a lot about engaging with legislators, so whether that's at the state, the federal, or the local level, we're always in community, making sure that they know where we stand, and again, supporting those other advocacy groups and community organizations. So if we can support, if we can, stand in the gap wherever, that's something that we are always there willing to do. So next slide. We also host town hall meetings. One of the things that we're really proud about is doing a lot of partnerships with our local institutions like WashU, SLU, UMSL. So last fall, we had an opportunity to host a panel discussion around men and their access to health. So this diverse pool of men, again, all across the region of Missouri came together to really just talk about the barriers and the access to healthcare that men tend to have. So that was a really great conversation. And we love hosting town hall meetings because, again, that's another opportunity like the listening sessions to capture input from community in ways that we can continue to support and advocate and change policies. We also provide testimonies during board meetings. So as you all know, in St. Louis City, we have a new administration. So as they're preparing their budget, we wanted to stand up and speak out against the importance of supporting the St. Louis Department of Health. Like I said before, we've done a lot of collaborations with the Department of Health. And so we want to make sure that not only they continue to get their funding, honestly, we were asking that you increase their funding because a lot of the services that they provide in community are important. And we, again, are a strong partner with them and want to make sure that we are supporting them in that effort. So providing testimonies when necessary. We also participate in voter education outreach. We've partnered with some of the local institutions, Harris Stowe, like I said, UMSL, WashU, SLU, to just again and get these young people to get civically engaged because again, they're voters, their voice matters, and we want to make sure that we are right there at the center of that, being engaged with them to just again promote advocacy and the importance of getting involved in community. That is it. Do we have any questions?
I have it.
Oh, okay.
Sorry. Can you hear me? Great. I won't get too close because I know that
feedback.
some feedback for sure. But one of my questions is, let's say someone is immunocompromised or has a specific illness and they don't know where to start and they feel like they're alone. Where would you direct this person to?
Well, as you all know, there are so many different organizations, IHN, and everybody else that's up here, but and even our organization, I think that we like to definitely stand in the gap and connect people to those resources. So I definitely would say our organization. I would say IHN. I would say there are so many because I think it depends on what exactly you need. So if it's something around maternal health, you might want to go to Generate Health. You have Promo, you have I would say IHN, but the Institute. International Institute of St. Louis, Promo, you have Vivint Health, Williams and Associates. You have so many different organizations on the ground, depending on what that need is, that are there to serve. And I would like to think that if they can't directly help, they may be connected to somebody else who can.
Absolutely. Great. And let's see, do we have any other questions in the room? Oh, we have one over here. So what's the age range
middle
for your
school
youth
and high
program?
school. The Youth Ambassador Program.
Wonderful. And so next steps, if one of these organizations wanted to connect to maybe schedule an advocacy day, would that be with you? And then what does that look like planning from beginning to end, just like a short, step process?
As far as the advocacy days?
An advocacy day, or connecting with your legislator, or even maybe drafting a letter. How do they connect, or what does that look like?
Yeah, I mean, again, I guess depending on which organization you reach out to, but like, let's say that you did reach out to us around a certain cause, it would look like, coming to us, and one thing you want to make sure you do is understand like what that issue is, what that cause is. So for instance, like I know we're really pushing like Medicaid. Federally, they're making all of these cuts, and so we don't want them to touch Medicaid. So for us, it might look like if you came to us and was like, hey, we want to make sure they don't cut Medicaid. Let's get together, provide testimonies. You might want to find somebody that will be impacted by Medicaid and use their personal experience to talk about. So if we're writing that letter, we might want to say, hey, this person from this particular community, if Medicaid is cut, this is how it's going to affect that family. Couple that with some facts and show them how to go and again provide a testimony at a hearing and things like that. So we would, work with them and prep them and, just support it along the way.
Absolutely. And then lastly, what would you say to someone at a nonprofit, whether that's in leadership role, they're concerned about engaging because of politics?
And honestly speaking, I think right now that's something that's really, really pressing, because now we can't use certain words like equity and, depending on who you are. So with our organization, we're not receiving federal funds. So, I feel like we still kind of have that, position where we can speak out about things. But let's say we have a partner organization that right now their funding is based on the fact of like you can't use equity or you can't, say certain words, right? So then we can stand in the gap to say, hey, as a supporter of these organizations, and we don't have to say your name, but you would know that we're still supporting you by the way that we still boldly speak out about that. So I think that, again, just understanding what you can and cannot do, but remain connected with those organizations and that's out in the community that still can speak up for you.
Amazing. Well, thank you so much, Asia, and let's give her a round of applause. Thank you, everybody. All right, Dr. Quinn, you are up. Wherever you feel most comfortable.
Well, good morning, everyone. Firstly, Gabby, thank you to you and your colleagues for putting on this really important event. I'm a very proud Irishman, and where I come from, healthcare is not a commodity, it's a human right. And I think these conversations need to continue. So my name is Michael Quinn. I serve as the president and CEO of Autism Support Now, which is the largest Medicaid applied behavior analysis provider in the state of Missouri. We have currently 10 clinics. I'm based in Florissant. I'm happy to say we're in the process of opening up a second clinic in Florissant. So if you have any questions regarding that, my colleague Michaela is here. Michaela, you want to raise your hand? And please connect with Michaela or myself. So in the last number of weeks and months, there's been a lot of conversation pertaining to autism on a state and federal level. So for example, in Missouri, the data will show that 1 in every 41 children has an autism diagnosis. That affects children from all racial, ethnic, and socioeconomic groups. On a national level, the latest data shows 1 in every 31 children have an autism diagnosis. Prior to that, it was 1 in every 36, which represents a 17% increase in prevalence. Now, the question is, what's driving these numbers up? And maybe that's a conversation down the road, Gabby, but certainly from a state level, there's more sophistication around detection, screening, evaluation, and diagnosis. A lot of institutions are working more in partnership and collaboration with one another to ensure that children are getting access to care. And we're seeing that more and more children from minority communities are getting access to care, but we still have a lot more work to do. ABA, what is ABA? Applied Behavior Analysis Treatment. According to the American Academy of Pediatrics, it's considered the gold standard treatment modality for autism. Why is that? Well, we know from research that if it's done with fidelity, in other words, if it's done correctly and properly and so on and so forth, It creates the best outcomes pertaining to language, expressive language, receptive language. It also creates the best outcomes pertaining to behavior. Many of the children that we see, and it was mentioned here this morning, we're not just trying to respond to autism, we're actually responding to a lot of trauma. And if you can create a situation where children and families have the resources they need to, shall we say, self-regulate, then the opportunity to implement other treatments and have impact is far greater. So we look at not just autism, we look at also the holistic profile of each child, because no two children are the same. Again, there's been a lot of commentary lately from the federal government regarding autism and Medicaid. 70% of our participants are Medicaid beneficiaries, and we're very proud of that number. And we're not going to lie down and take a lot of the rhetoric that's out there right now regarding Medicaid cuts. If you cut Medicaid, essentially, you're hurting the most vulnerable in our community. And one of the reasons why I'm based in Florissant, and I'll give you a little bit of context, if anyone has been fortunate enough to visit my country, it's a beautiful country. I grew up in a community very similar to Florissant. I'm one of 5 kids. None of my siblings graduated high school. My parents never owned a home. I was very lucky, got a sports scholarship, got an education. And if you're not helping other people, well, what are you doing? And what I love about this organization, and I commend Gabby for her leadership, is where the rubber meets the road. It's not in the academic institutions, respectfully, it's in the community. And we are in the community, and we're on Dunn Road, we're opening a second clinic, and we would love to partner and collaborate with as many people as possible. And I'm happy to address any questions or comments there may be, but that is it in a nutshell. So thank you for your time, folks.
Absolutely. Thank you. So at Autism Supports now, you have registered behavioral technicians. Can you explain a little bit about what that is and what that training looks like to become an RBT?
Yeah, so I don't want to put Michaela on the spot, but she's one of our awesome RBTs. So Michaela, do you want to talk to that?
Thank you.
No pressure.
Little pressure. So I've been an RBT for going on about 4 years now. So when we are trained, we do modules and we do on-the-floor training. It looks the same no matter what clinic you're in. In order to be registered, you normally have to take a board-certified test. We have to complete 40 hours of training. So that includes like learning just like how to do the behaviors and things. And then we are under a BCBA, which is a board certified behavioral, analyst, sorry, little nervous. So they normally make the treatment plan, and then as an RBT, we follow it out. So we work directly one-on-one therapy with kids, always. It could be clinic-based, home-based, or at school-based. And normally what we do is the BCBA will work very closely with parents to see what they would like to improve on or, what behaviors their child is facing. And then we would take that and they would write up a treatment plan and discuss it over with parents, have a signature. And then that's where we would come into play and we do the one-on-one and we work closely with the child to make sure that we are implementing any treatment that they need or like following protocols and things so that way we are able to help the child with their behavior.
I will say just from experience of working with, shout out to Lexi Bryant, who is also a ASN employee. She was asking me personally for where can I take my families to get a haircut. I will go with them. I will find somebody. And so we work together to find those connections where the family, the barber or their hairdresser could actually, or has that experience and that knowledge of how to treat a patient or even a client in the chair when they are on the spectrum. And so I thought that was really special. She's also mentioned going shopping with the grocery store. What does those behaviors look like? So you really are getting the full service at ASN. And so we're very excited to have them in the North County region. Another question or does anybody else? Okay.
I have lots of questions. Glad to hear about you all services. What is the age range of youth that you all service? And then my other question is, at the point of receiving services from your agency, does the youth already have to have been diagnosed with autism, or do you all support that appointment? I used to work in the child welfare, and those appointments dated months to try to even get a youth seen to be diagnosed, even though they exhibited symptoms. So it's kind of like a two-part question.
Sure. So in terms of age range, the youngest children we serve are 18 months, and the oldest we serve is 14. I think we've got a 15-year-old coming in soon. In terms of screening, evaluation, and diagnosis, we don't do that. But we do work with various institutions that do that. For example, we work very closely with the autism program at Mercy. We receive a lot of referrals through WashU's autism program also. Your name is Miss Tatum? Does that answer your questions? Yeah. But be happy to connect after this session.
Absolutely. Oh, great.
Okay, so I have two questions. With the training that they do over there, do they also show the parent how to deal with their child who has autism as well?
Yeah.
Like, can they be included while you guys are showing them? Because that way they could bring that home. And then the second question I have, I'm a Latina, but I speak English. What about the people who don't speak English? Do you guys, because I see the spectrum going higher as well, and most parents, especially in the Latino community, we ignore it. We just act like if it's not there, and they don't educate their child or themselves, right? So how do you guys deal with the specific, any other race, but I'm going to ask about the Latinos.
Sure, great question. Your name is Miss? Melissa. So it is a requirement that there's a parental, well, we don't call it parental, we call it caregiver element, because many of the children and families we serve, they come from a variety of families. So one of the criteria, and it's non-negotiable to get into the program, there has to be a commitment to routine, what we call family guidance sessions. And what essentially that means is, and Michaela, my colleague, mentioned, the BCBA, the Board Certified Behavior Analyst, will meet routinely with the parents to discuss developmentally what's working well, what's not working well, and what you can do and your wider family and community can do to reinforce some of the best practices in home and, most importantly, in the community. So it's a prerequisite. It's also an insurance requirement. If parents are not routinely engaging with the service, then that potentially runs the risk of them losing coverage. So that's the first part of that. And then, sorry, remind me again of what the second. Yes. So several of our colleagues speak Spanish. I don't. I speak Italian and I speak Gaelic, Irish Gaelic, but that's no good to you. Several of our colleagues are actually, several colleagues speak Spanish, and that's never an issue. I mean, we had recently a family from the Middle East, and I'm thinking, how are we going to navigate that? So I reached out to a friend of mine who lives in South County, and they're from Mosul in Iraq. Obviously, they speak Arabic. So we had that person come along and act as the interpreter. The great things about challenges is always solutions. But yeah, we work with families from all parts of the community, and the Latino community is no different. Yeah, you're welcome.
Yep.
How large is your organization? Because this isn't so needed, and we're gonna blow up their phone, right? So you have a big.
Yeah, it's a good question. I mean, if you look at the numbers of children that are impacted, there's fewer providers than there are children living with autism. So the numbers are upside down. We are open to significantly growing our footprint in North County specifically because it's grossly underserved. We've been in Thorson for almost 2 years. We're in the process of opening a second clinic. Why not opening another clinic? Why not open a third clinic, a fourth clinic? Because the need is there. And again, I don't want to, when I say this, offend anyone from the academic world, so to speak, but where the rubber meets the road, it's not in the institutions, it's in the community. And that's where we are, and that's why I'm proud to say that over 70% of our beneficiaries are enrolled in Medicaid. And we're not going to change that policy, irrespective of the rhetoric at a state or federal level. We're just not going to do that. So the more people we can serve, it's God's work, and that's what we want to do. Yeah.
Thank you so much, Michael. Thank you. We will save any questions for the end, and we will move on. But thank you again so much. All right. Last but not least, Roy Whitley.
Good morning, everybody. I know we're getting close to time, so I'm going to be mindful of that, but I am one that goes over a little bit. But I'll talk a little bit about ARC's outreach. So I actually have the honor and privilege to serve as our president and CEO. And what RX Outreach is a nationwide mail order pharmacy that serves in a nonprofit space, right? And so when we seek to remove or reduce barriers, we're looking at things like financial barriers, social barriers, geographic barriers. And I think if you kind of take a step back, ask yourself a quick question, do you know in your network or the communities that you serve someone who's suffering from access to affordable medications, whether that be they don't have the financial means to do it, maybe they're a high deductible plan, maybe they're on Medicare plans, and some of the drugs that they need to take aren't covered by their plans. That's what RX Outreach is there for, right? Think about even rural communities as well. Gabby, you can go to the next one. So kind of hit the mission already, if you want to. So talking a little bit about RX Outreach. So we were started back in 2010 as a nonprofit, and since then we've serviced over 600,000 patients and counting. On any given month, we'll serve 10 to 12,000 patients, of which about 2,000 are new first-time patients to RX Outreach. And over that time, we've saved patients over $1 billion and shipped about almost 4 million prescriptions. We're pretty close to that here. We'll probably surpass that by the end of the year. So who we serve, I touched on this a little bit, but really the misconception sometimes about RX Outreach is that it is just here for individuals who are having financial difficulties, but it's much larger than that. And I touched on some of those topics, right? So for us, it's about partnering with other amazing community partners that are serving individuals, whether it be adolescents, aging adults, young adults, the homeless, justice impacted individuals, you name it, regardless of immigration status, income, ethnicity, age. That's what we're here to do. And so from a program differentiation standpoint, there's no membership commitments, right? So we don't operate like a discount card or anything like that. In fact, we kind of work alongside community pharmacies. We actually have one ourselves where it's really about if a patient is not going to get the medication for any reason, or they're at the counter and they're leaving that medication there for any reason, we want to talk to them. 3 primary programs. So I've been talking a lot about the patient-centered medication program. So I'll kind of skip through this one, but one of the things I do want to point out here is this buy a med, give a med comment. A portion of every prescription that is filled at RX Outreach, we use those dollars to support the community network programs that we have in our Fill the Gap program, which right now is a free med program specifically piloting around aging adults ages 55 to 65 in the St. Louis region. Community partner network, so touched on this a little bit, but really what this is partnering with agencies like the ones many of you guys in the room represent. Because we're nationwide, we have various partners in this network as well, but what we try and do there is work with the community networks to further discount the medications, right? We partner on grants and things of that nature as well to try and make sure we're keeping medication costs as cheap as we can. And in some cases, they're even free outside of our Fill the Gap program. In addition to that, we do have a community pharmacy in Delwood in the R&R marketplace. And so we're very proud to be there because in this space, it's a little bit different than what we do at our mail order site, where the mail order site doesn't do insurance. But here in Delwood, we're able to respond to the community by way of Medicaid, commercial, Medicare, but it doesn't stop there, right? Because as a community pharmacy, you still see the patient show up and sometimes can't afford the med. And so because of what we do on the mail order site, we have that partnership that we actually don't have to send that patient home empty-handed, right? We can work together with the mail order site to really take care of the patient's needs. Not to mention, it's no secret there's pharmacy deserts being created all over. And so, we're able to respond there as well by way of delivery for individuals who may be having transportation barriers in the North County area. And then lastly is the Fill the Gap program. So I mentioned this one is a pilot right now. You can hit the next slide for me, Gabby. Right now in that pilot, it is for individuals living or suffering from cardiovascular, diabetes, asthma, allergy, who are at or below 300% FPL, ages 55 to 65. It's fresh. We just launched this late February. But we are actively looking to expand that with various community partners, whatever that might look like. And the whole idea here is to be able to give free medication to individuals who don't have the financial means to be able to do it, but also partner and talk about some wraparound service and some educational things to really just improve the health equity in our area. And that's it. So I didn't realize that was my contact info up there, but my contact info is up there. And I have a colleague sitting behind the wall here, Katie, as well. Really excited to kind of double down in the St. Louis area in our own backyard to partner with agencies to really improve health equity in St. Louis. Both of us kind of living here in the St. Louis area take a great deal of passion in making sure we improve the area.
Great. So questions. My first question, Roy, is you serve a national platform. How do you do that? What does your team look like?
Great question. So we have a team of about 44 employees made up of what we call health coaches, pharmacists, and a couple of admin folks. Primarily, most of our staff are our health coaches, and so they're doing the data entry services. They're on the phones talking with patients all day, every day. They are actually at Arcs Outreach. It's not just about giving the prescription, but it's also about helping the patient get connected to the resources in their communities that they need to be connected to. And so on any given day, we're up to about 700 to 800 calls a day that the team of health coaches do. And then we have a team of about 4, I would say, full-time pharmacists, some work in part-time capacities, but that's how we do it.
Amazing. Any other questions? No? What are some of those popular medications that are coming out that you see a lot?
Man, that's a good question, Gabby. I can't tell you medications, but I can tell you disease states that we see a lot, right?
Absolutely.
Mental health, diabetes, cardiovascular, some of the other ones, arthritis. One of the ones that's kind of new to us as we continue to expand the various disease states that we kind of operate in is also MS. We're starting to see a lot of.
Wow.
And so we're proud to, kind of be able to do what we do because there are medications out there, especially in MS, where it's, hundreds of dollars that we're able to do it for $50, $60, right? And so that's just the impact of what we're able to do. And then ultimately, for some folks, it's even free.
All right. We have a question from the panel.
Right. Just a question in terms of cost of medication.
Yep.
There's a lot of conversation at a federal level around reducing costs.
Yep.
What are you hearing? What are you seeing down the road? Because many of the families that we serve, not just here in Thorson, but beyond, a major challenge is when they're, getting medication for their child to address some of the comorbidities.
Yep.
They can't afford it.
Yep.
So what does that look like down the road? Or
Yep. Great question. So much like other nonprofits, RX Outreach isn't immune to challenges around fundraising and things of that nature, right? So we seek to do grants, we seek to do partnerships to try and go after dollars and contracts, right? To go after dollars to try and do stuff ultimately free. But the other part of the model that I think for us that's unique and different is this buy a med, give a med kind of philosophy, right? There are going to be individuals out there who don't necessarily need the RX Outreach platform or program, but maybe they want to be philanthropic in their heart, and this is kind of an easy way for them to do that without having to, give $1 or $2 or stroke a check to support, all with the intent of further subsidizing, ultimately getting to serving as many people as we can from a free medication standpoint.
Amazing. Well, to be respectful of everybody's time, it is 10 o'clock. Please follow all of these organizations on LinkedIn. They are constantly posting great information and constantly updated as well. If you have questions, please connect with them afterwards. We also in the room from health. We have IFM. They are a low cost or clinic that also does uninsured or underinsured patients, and they are located around the St. Louis region. They also have people who speak multiple languages. We also have Bell Children's Services that is located in most of our early childcare centers that are supporting special needs. And then we also have, who else do we have? We have Marquita, who's from CHADS, which is a mental health services that's located in Lucas Crossing Middle School right now. And we have iThrive, who has their glasses bus and offers free glasses and eye vision, as well as Delta Gamma. We have Noreen Conti. So please connect with each other. And thank you so much for coming. Again, we have a survey. Go ahead and take that survey. Let us know what you want to see next in the healthcare space. And that is it. Thank you again so much.